I think that for CAR T cells, we now have 3 products that are very, very interesting. So the update on the axicabtagene ciloleucel with the recent New England Journal publication really shows a flat, durable response rate with around 42% of people staying in remission at around 15 to 18 months. And this was updated a little bit at EHA this year. And there was also at ASCO and EHA, there was some data suggesting, again, that patients earlier on in the treatment course, or those with potentially less tumor burden, might do better. We're also learning more about escape mechanisms in that setting. So in patients who relapse, there's kind of 2 patterns that have been seen. One is some patients lose CD19 expression. So in that case, there's a selection of the tumor cells to not express CD19, so the CAR T cell couldn't do anything further to be able to essentially get rid of that malignancy. And in other cases, the tumor expresses a suppressive environment, such as PD-L1, and that can interact with the receptor on the T cells and essentially turn them off. And so that would lead to interest in combination studies, which are also ongoing. The Juliet trial was also presented and hopefully soon to be published and FDA approved. And that is a different CAR. It has a slightly different toxicity profile. It seems to allow an outpatient administration in some cases, and also has encouraging results. The studies are different. The patient populations are slightly different, and so it's hard to directly compare them. But that's also encouraging, obviously led to that FDA approval. Then the third trial, the Transcend trial from Celgene Juno with JCAR17, and in that setting, we have similar outcome, high response rates, high CR rates that certainly seem comparable, but there's surprisingly a lower risk of severe toxicity. So the cytokine release syndrome, grade 3 and above by Lee criteria, was only seen in around 1% of patients, which is quite a bit less than what was seen in the other 2 products.